Good afternoon, everybody. Thank you for joining the ONC HTI-2 Proposed Rule Overview Information Session. My name is Josh Shapiro with Capital Consulting, and I'll be assisting with the logistical support for today's session. If you need any technical assistance, please click that chat icon at the bottom of your screen, type your issue into the chat, and one of our techs will respond to you. Please be aware that today's session is being recorded. Closed captioning is also available by clicking on the CC icon at the bottom of your screen. Now to get things going, I'm going to go ahead and turn it over to Beth Myers at ONC.
Thank you so much. So welcome everyone to the Health Data, Technology, and Interoperability Proposed Rule Overview webinar. Today's webinar, we have a fairly significant group of subject matter experts from ONC who will be presenting briefly on the entirety of the rule. As you may know, it's more than 1,000 pages in PDF format. So quite a lot to cover today, and we're going to dive right in just a moment after some housekeeping items. If we want to move to the next slide. So a couple of things. So the rule has been submitted to the Federal Register, and a version has been made available on the ONC website. That's healthit.gov/proposed-rule. And you will see that information being shared with you in the chat and so forth as well, so you can be able to get to those links. However, the OFR process is still ongoing. So when the OFR process is complete, the rule will display as a read-only file on the Federal Register. And then following that, the rule will be published in the Federal Register for public comment. When that publication occurs, the public comment period will begin on the Federal Register. At that point, we will update our website and our listserv messages to send out to folks as each step throughout that process changes and those updates are made. So that last step of publication and the public comment period opening will also determine when the public comment period closes. So that's just something to be aware of. We will keep you posted as we continue along that. For this presentation, the materials in this presentation are based on the proposals in the Health Data Technology and Interoperability, the HTI-2 proposed rule. While every effort has been made to ensure that the accuracy of this restatement of those proposals is clear, this presentation is not a legal document. Again, the rule has been submitted to the Federal Register. The display version and then the final publication version are what would be the official document or the source of truth on which you should comment if you are going to be making public comment on that rule. So the other thing to just be aware of is there will not be a question and answer session during this webinar, and that is due to, first off, the amount of content that we are trying to cover in an hour, but also that we are required to protect the rulemaking process and comply with the Administrative Procedure Act. So during the rulemaking process, ONC can only present the information that is in the proposed rule as it is contained in that proposed rule. We cannot interpret that information or clarify or provide further guidance beyond the scope of what is within the NPRM. In addition, we cannot address any comments made by anyone on this webinar or any other informal means, including individual meetings or other formats. So that comment that you might be interested in making, clarification that you are seeking or suggesting needs to be made through the formal comment submission process on the Federal Register when that publication happens and the Federal Register comment period is opened. So with that, we will move on to some substance. Next slide. All right, the agenda for today, I'm going to talk a little bit about the purpose of this rule, and then I'll be handing off to my colleagues who will be going through the certification standards and functionality updates in the proposed rule, including some in-depth information on the public health criterion and the patient-provider-payer APIs that are proposals within the rule, looking at the use of application programming interfaces for a wide range of use cases. But to give you a heads up, at the very end, we'll also be pointing out the availability of additional webinars that will be taking deeper dives on a couple of topics. And then we'll be passing it to another member of our certification team to go through some of the administrative programmatic pieces, and then a member of our regulatory team who will be talking through the information blocking proposals as well as the TEFCA proposal. Next slide. So the purpose of this rule is to continue implementing provisions of the 21st Century Cures Act, including an API that allows EHI to be accessed, exchanged, and used without special effort. Really important concept there that we have in regulation, both for proactive application programming interfaces within our certification program, as well as policy considerations around things like information sharing and establishing the how the parameters around that technology is made transparent, and things like licensing and fees. So all of the things that we did in the 21st Century Cures Act final rule, things that we built on HTI-1, this is taking all of that another step further. It is also taking a look at several administration executive orders, including things that are thinking about public health and public health threats, health equity, and ensuring the advancement of the necessary information to support underserved communities and advance health equity and reduce health disparities, as well as thinking through ways to connect the dots in different parts of the department to ensure that the whole sort of scope of health IT landscape is being considered and supported in a unified manner. In other words, being good stewards of the public dollar. And then finally, the last thing that it's really advancing is our core purpose and our core function, which is leveraging health IT to advance interoperability, to build a nationwide health IT infrastructure. So that is our statutory duty, our reason for existing, and this rule, we believe, is really taking some important steps forward in our proposals to make that happen. If we can go to the next slide. So we're proposing to advance the nationwide health IT infrastructure. I sort of mentioned some of these things. We're looking at things that can help to minimize data silos and emphasize solutions that are easier to adopt, especially for this says settings, but also for entities or users who may not previously have had incentive dollars to be able to access technology or adopt technology, and really allowing them the opportunity to leverage modern technologies that are more innovative and potentially less substantial from a point of view of the actual implementation burden on the user in order to really advance their ability to connect and exchange data with other partners. So those are some key priorities that we are thinking through. We are also thinking about advancing equity and thinking about supporting patients' access to lawful reproductive health care, and then finally strengthening support for honoring a patient's individual privacy preferences. So these are sort of a summary of the main goals that we're trying to accomplish with this proposed rule. So we can go to the next slide. At this point, I will be handing off to Robert Anthony, the Director of our Certification and Testing.
Thanks, Beth. I am going to cover very quickly and at a very high level some of the new and revised standards and certification criteria that are presented in the NPRM. We have a number of criteria that are revised because we are updating particular standards in areas, some criteria that are being revised because of functionality, and of course, some entirely new criteria that include both functionality and new standards. This will be very high level. We have a number of different things, as Beth said, to present. So I do encourage everybody to take a look at the regulation that has been proposed, and particularly in the preamble discussions for more in-depth discussion of these. Next slide. The first thing is that we are proposing a diagnostic imaging hyperlink. This is actually will impact a number of criteria like B1 transitions of care, E1, which is the view, download, transmit, G9 and G10, which are API criteria. Basically to provide support for capturing and documenting any hyperlinks to diagnostic imaging. Important to note here that we are not proposing a specific standard associated with that functionality, nor are we putting any kind of a requirement around end users actually populating specific information to the hyperlink. This is about making sure that diagnostic images, which are often stored in systems external to the EHR, there is some sort of a hyperlink functionality that can encourage more widespread integration. Next slide. We are proposing to revise the clinical information reconciliation and incorporation. We call that CIRI criterion. That is the B2 criterion, and we have put two proposals down. One is a primary proposal, which would be requiring expanding SIRI from what is now problem list, medication allergy to all of the US CDI data elements. We also have an alternative proposal there to require a more limited set of the additional US CDI elements. But again, all of this is really around additional support for the patient record and providing more benefit for providers in some of the additional functionality we have required around enabling some user-driven automatic reconciliation that can be automated, some rules-based throughout the Health IT module. Next slide. We are updating the required US CDI version to version 4, or proposing to do that by January 1st of 2028. US CDI 4 adds 20 new data elements that include things like behavioral health and support for marginal and underserved communities. This would impact a number of different criteria, and the next slide will show you transitions of care, SIRI, decision support interventions. All of these have US CDI underrelated. So the proposal to move to the next version of US CDI version 4 by 2028 impacts a number of different criteria in this area. Next slide. We are proposing to revise the current electronic prescribing certification criteria. The primary proposal here is to update to the NCPDP, National Council for Prescription Drug Program script standard that supports it, to the 2023-011 version. We are currently on the 2017-011 version. This would move us to a more recent version. There are some additional proposals here about removing some of the optional transactions that we currently have within that B3 e-prescribing proposal. Next slide. And then finally, in new criteria, we have a real-time prescription benefit certification criteria that we are proposing to enable exchange of patient eligibility, medication coverage, benefits for different medications and pharmacies, identification of coverage restrictions where they exist. We are proposing to use NCPDP's RTPB standard version 13 in this area, and including that functionality of the B4 RTPB criteria within ONC's base EHR definition, the base functionality that would be allowed. We think that, expanding to use this criteria will really enable prescribers to interact with patients about financial impacts of different prescriptions and ensuring that at the point of care, patients can receive the right and most affordable medications here. Next slide. We also have a handful of revisions to existing security criteria. I'm going to go through these very quickly for folks. Next slide. Our D7 criteria is a end user device encryption criteria, and we are proposing some new criteria or new requirements within this area to encrypt personally identifiable information that is stored both on end user devices and also on local or server side devices. We're also proposing to adopt the latest FIPS Annex A standard, which would update from the current version, which is the 2014 version, to a more recent 2021 version. Really, this is about updating requirements to align with the latest NIST-approved encryption algorithms and providing for better device encryption security. Next slide. Folks who are already participating in the program are probably aware of the B13 criteria about multi-factor authentication. Well, we implemented this during cures. At that point in time, we really just asked people to indicate yes or no, whether they were incorporating multi-factor authentication into their products. But we are proposing that D13 be accordingly updated in the privacy and security framework to actually support that multi-factor authentication. And you can see that impacts a few different criteria in here, but really this is about bringing health IT security up to match most of the industry best practices around information security. Next slide. And then you see something similar with the D12 encrypting authentication credentials. This again is about bringing, I think, health IT security in line with industry standards, moving from a yes/no attestation requirement to a requirement to actually encrypt authentication credentials. We're proposing, again, a standard, the Federal Information Processing Standard, the FIPS standard, to use for those encryption of authentication credentials. And with that, we'll go to the next slide, and I will pass it on to the next presenter.
All right, if we can have Molly Prieto, who is our deputy in our standards.
Absolutely. Thanks, everyone. Good afternoon. We can go right to the next slide. Thank you. So like Rob mentioned, we had quite a few updates within the certification program. Several of these are related to components of public health data exchange. We took a three-part approach to updating and creating new criteria for public health data exchange. One of those that we did updates to existing criterion for reporting public health data to the newest and most up-to-date standards. We additionally proposed several new certification criteria, both within the transmission of public health information, and then net new and exciting, the ability to receive, validate, parse, and filter incoming public health information. And then lastly, we also proposed a new standards-based API, which is G20 within the rule for public health data exchange. And we believe that this three-part approach will do a lot with being able to advance tools that can be used in a variety of ways across multiple programmatic programs beyond public health. We also believe that this will allow for public health and health IT to update and progress along the same timeline and using those same standards. And on the next slide, we can dig into some of those specific updates. So I imagine that F1 through F7 look pretty familiar, but F1 through F7 were existing criteria in the certification programs. Many of those, as you can see here, we updated to current versions of HL7 standards. We do have that standard detailed there, so I won't read it for the entire group, but we are updating to either HL7 version 2 standards for many of these, and in some cases, also proposing HL7 FHIR standards there. In addition, we also created or proposed two new criteria that you can see on the bottom of this slide: birth reporting, which is F8, and prescription drug monitoring program, which is F9. On the next slide, you can see the new suite of receipt, validate, parse, and filter criteria. These are corresponding with the F1 through F9 programs criteria. So you can see here we have one for immunizations, syndromic surveillance, electronic lab reporting, cancer pathology reporting, electronic case reporting, birth reporting, and prescription drug monitoring program. And these criteria that live in the F20s, these, like I mentioned earlier, are for receipt, validating, parsing, and filtering that incoming information. We are pointing to the same standard that was referenced in the F1 through F9 criteria to ensure that there is that corresponding functionality and that the sending and receiving of the public health information will be done so adhering to the same standard. Next slide. And that third component here that I mentioned earlier is the standardized API for public health data exchange. And so G20 is building off of the current criteria at G10 and making sure that those functions are also available for public health data exchange. And we believe that this will be a really important first step towards furthering that FHIR-based ecosystem, and that this will be one of those steps that can reduce reporting burden for healthcare organizations and developers, and allowing public health agencies to have access to critical information that they need to do their work. One of the proposals that we included was by requiring support for the FHIR resources that are profiled in the U.S. Public Health Profiles Library Implementation Guide, and did ask for feedback and comment on that. And we also believe that by having G20 in place, that we'll be able to have some ongoing and future development of public health FHIR implementation guides that can really help further the criteria mentioned through the earlier slides in the F components. And I believe that is all for the public health, so I'll pass here.
Thank you, Molly. And we'll pass it to Alex Baker, who is in our policy office in the federal coordination.
Great, thank you so much, Beth. So I want to talk about a series of proposals in this rule that are coming under the title Patient, Provider, and Payer API Capabilities. So this is a set of proposed certification criteria at 17315 G30 through 36. And these use a set of FHIR implementation specifications and other implementation specifications that we are also proposing to adopt in this rule. These proposals specifically align with a series of policies that CMS has finalized over several recent rulemakings that are designed to create requirements, API requirements for certain payers to meet that CMS regulates to improve interoperability and support other features that are important to effective information sharing. These criteria are intended to make health IT available that can help reduce burden associated with certain administrative processes and increase patient and provider access to important healthcare data held by payers by certifying technology that ensures that technology is meeting interoperability standards to carry out those functions. Next slide. So the first proposal here is under the Patient Access API proposal, and this specifies requirements for health IT can be used by payers to enable patients to access health and administrative information using a health application of their choice, including payer drug formulary information and patient clinical coverage and claims information. And this proposal references certain standards that are proposed for adoption here, including the Karen Blue Button IG, the Da Vinci PDEX IG, the Da Vinci US Drug Formulary IG, and the US Core IG that ONC has already adopted. And benefits here include benefits such as making this data available to patients that is currently held by payers to increase their ability to make decisions about their care. And this aligns with the CMS proposal for impacted payers to stand up patient access APIs, which were originally finalized in the interoperability and patient access final rule. Next slide. So we also propose a provider access API, which is focused on two different criteria that would ensure that both payers have technology available that they could use to make information available to healthcare providers, and that healthcare providers have certified health IT available that they can use in order to receive that information, including patient clinical coverage and claims information. And this proposal again references the Karen Blue Button IG, the Da Vinci PDEX IG, and the previously adopted US Core IG. And benefits here include the ability for payers to receive information about their patients, both administrative and clinical data that may be held by payers that can help to better support their decision-making and participation in value-based care. And this certified health IT would align and support the provider access API requirements finalized by CMS in their interoperability and prior authorization final rule. Next slide. So the next proposal is around a payer-to-payer API, and this focuses on a certification criteria for health IT that can be used by payers to support electronic exchange between payer systems. So supporting payer systems exchanging information with each other when a beneficiary changes coverage and payers want to support care coordination for that beneficiary. This aligns with CMS requirements for payers to establish a payer-to-payer access API, which was originally finalized in CMS interoperability and patient access final rule. but has been updated in the most recent interoperability and prior authorization fund rule. Next slide. Next, we have two criteria under prior authorization APIs. So there is a proposed prior authorization API provider and a proposed prior authorization API payer. Two different certification criteria which focus on the ability for providers to request coverage requirements and assemble and submit documentation for prior authorization requests, while there is also the payer side criterion, which would support payers' ability to provide information about coverage and documentation requirements and receive prior authorization requests from providers. And these two criteria reference several IGs that have been developed by the Da Vinci Project, including the Coverage Requirements Discovery IG, the Da Vinci Documentation Templates and Rules IG, and the Da Vinci Prior Authorization Support IG. And we believe that these criteria have the ability to reduce administrative burden that is associated with the prior authorization process through streamlining that process, which can enable patients to receive more rapid information about whether treatments are approved and ensure that they receive the right care. And these two proposals would align with and are intended to support CMS requirements to establish prior authorization APIs by payers, as well as a final policy which CMS also finalized to create a prior authorization measure in both the Promoting Interoperability Performance category of MIPS and the Promoting Interoperability Program for hospitals. And one more slide. So the final proposal here is around a provider directory API health plan coverage criterion. This proposal is for a criterion which specifies technical requirements for health IT that can be used by payers to publish information regarding the providers that participate in their networks. This proposal references the Da Vinci PDEX PlanNet IG, which we propose to adopt. And we believe that this would enable patients to understand the providers, facilities, and pharmacies covered by their current or future plan to improve their decision-making. And this also aligns with and is intended to support final CMS policy around a provider directory API that has been originally required in the interoperability and patient access final rule. And with that, I will turn it back to Beth.
All right, thank you, Alex. And we will be passing next to Jeff Smith, who is the deputy in our certification and testing division.
All right, thanks, Beth. If we can go to the next slide, please. Okay, so consistent with what you've heard so far across various certification criteria, we will be updating our existing certification criterion for standard API for patient and population level services by adopting newer versions of various standards, such as US CDI version 4 and the Smart App Launch Implementation Guide 2.2. We are also proposing to require that modules certified to G10 support new capabilities, such as dynamic client registration, as well as new kind of what we call API workflow capabilities, such as workflow triggers, verifiable health records, and subscriptions. We are also proposing that these health IT modules support multi-factor authentication, as Rob noted earlier, and imaging links, as well as support for read and search for API system applications. And we are also proposing that these modules support the type query parameter for bulk FHIR API requests. There are a number of benefits that we believe these enhancements and updates would ensure. Those include that patients have access to more information, such as diagnostic images via imaging links, more granular control of their data through US core scopes, and more modern experiences connecting apps of their choice to their health information via dynamic client registration. We also believe that clinicians would benefit from an expanded use of standard APIs required under US CDI version 4, including access and exchange and use of data elements salient to behavioral health and underserved communities. Clinicians would also have a range of tools, including CDS hooks and subscriptions with which to support decision-making and manage patient information. And then last but not least, public health and researchers and others would benefit from improved access to bulk data through required support for the bulk FHIR implementation guide version 2. Next slide, please. So here is a kind of depiction of where we're proposing various standards move to. You can see that we've got new standards for information access and authentication and authorization. Again, moving from US CDI v3 to v4, which is of course supported by the US Core Implementation Guide v6.1 to 7.0. We're also proposing the Bulk Data Access Implementation Guide version 1.0 moved to version 2, and then moving the Smart App Launch IG from version 2 to version 2.2. I mentioned that we're looking to have G10 modules support dynamic client registration. We are pointing to the HL7 FHIR Unified Data Access Profiles, or UDAP, Security IG version 1. And then you can see under the API workflow capability standards, we are pointing to the latest version of CDS hooks, as well as the Smart Health Card Framework 1.0, supported by the Smart Health Cards Vaccination and Testing IG. And then last but not least, the API-based event notifications using the HL7 FHIR subscriptions R5 backport IG. Next slide, please. Okay, so alongside that, we have established proposed to establish 14 new certification criteria at section 170.315J titled Modular API Capabilities. Now, a lot of these certification criteria are substantially similar to capabilities currently referenced in the G10 API criterion, such as the functional registration and Smart App Launch user authentication. And then other of these J criteria reflect those API capabilities that I just mentioned, including CDS hooks, Smart Health Cards, and FHIR subscriptions. I think when you look at the reg text for the J criteria, and you look at how we compile these or use these J criteria or reference these J criteria across several of our API criteria in 170.315G, what we're trying to do is make the regulation text just a little bit more computable. And so you'll see references, but many of the same capabilities that exist in G10 will remain. We're just referencing them through the certification criteria in J. We do think that this approach will make our programs, modularity will improve that ability, and different modules will have the opportunity to combine different capabilities across the Health IT modules depending on their use case needs. And this will provide more flexibility for Health IT developers that wish to certify to more discrete functions rather than these rather large multi-functionality and all-encompassing certification criteria. And then last but not least, we think that longer term, running or establishing these certification criteria, these modular API criteria, will support a growing number of clinical, public health, and administrative use cases to foster innovation and competition in these spaces by providing for more flexible modular development. All right, next slide, please. Okay, so now we're going to talk a little bit about some related conditions and maintenance of certification requirement updates. If you can go to the next slide. First, we are proposing to update the API conditions and maintenance of certification requirements at 170.404. So these API conditions and maintenance of certification requirements were really introduced in the Cures Act final rule and are an important complement to the technical conformance requirements for G10. And they establish requirements to promote transparency and pro-competitive business practices among certified Health IT developers in pursuit of that policy we refer to as without special effort. So these are policies generally that are intended to support access and exchange of use of EHI without special effort. The proposals in HTI-2 really fall into two buckets as it relates to the API condition and maintenance of certification requirement. The first set of proposals is really aligned with the new structure proposed for G10. So we're moving some existing documentation requirements that currently exist in the criterion at G10 to the API conditions and maintenance of certification requirements in 170.404. The second bucket of proposals really extend and enhance many of the transparency and pro-competitive requirements to other API criteria, such as the public health API criterion and the payer, provider, and patient APIs that Alex just covered in G30 through 36. We think that a lot of the important activities that have been applied to G10 that make access to technical documentation and other pro-competitive aspects of the conditions and maintenance of certification requirements ought to apply to these other certification criteria. And so that's really where the bulk of that activity is at. And we really do think that this will continue the effort mandated by Cures to facilitate more access without special effort using APIs. Okay, next slide, please. All right, I think this is the last one I'll have on my docket, but we are also going to make an adjustment to the attestations condition and maintenance of certification requirements. So for those of you who were watching and engaged in the HTI-1 process, you'll be familiar with the decision support intervention certification criteria in 170.315 B11. Well, what we are proposing to do is to revise the attestations condition and maintenance of certification requirement to add a requirement in that a health IT developer attest to compliance with the assurance maintenance of certification requirement B4. And this will really kind of enhance and support transparency and accountability in the program and support a health IT developer's ongoing compliance with program requirements. Next slide. All right, and I'll be handing it off to the next presenter.
All right, thank you, Jeff. I will be passing to Cassie Weaver, who is a policy analyst in our regulatory and policy affairs.
Thanks so much, Beth. So just a quick overview to start. In the information blocking section of the HTI-2 proposed rule, we propose to update some of the definitions associated with those regulations, proposed to update 2 of the exceptions and requested comment on a 3rd, and we also propose 2 new exceptions. I'll cover those 2 new exceptions in a little more detail, but please check the proposed rule to read how we propose to update those defined terms. And similarly, be sure to look in the preamble and proposed regulatory text for a list of practices that constitute an interference for purposes of information blocking. We propose some changes to the timing of responses for the infeasibility exception, propose to expand some of the subconditions in the privacy exception to provide greater clarity for non-covered entities or actors. And we requested comment on some aspects of the recently finalized TEFCA manner exception. Next slide, please. So the first new proposed exception is called protecting care access. And we proposed this new exception to apply to practices likely to interfere with the access, exchange, or use of electronic health information that an actor in good faith believes could create or increase a risk of potential exposure to legal action, including investigation, that the actor believes could be brought under a law in effect at the time the actor engages in the practice against patients, healthcare providers, or those who help make getting care possible, for the mere fact that a person sought reproductive care that was lawful under the conditions in which it was provided, or provided or facilitated such care, or where, if the patient protection condition applies, a patient has health conditions or history for which reproductive health care is often sought, obtained, or medically indicated. The benefits of this proposed exception include offering actors certainty that practices satisfying the conditions of the exception will not be considered information blocking. It would also assure patients that the information blocking regulations support actors limiting their EHI sharing in response to risks that arise over time, while continuing to support patients' access to their own EHI and other appropriate sharing of EHI consistent with applicable law and patient preferences. Finally, the exception also supports continued advances in digitization, interoperability, and public confidence in the nationwide health IT infrastructure. Next slide, please. So to make this proposed exception a little more understandable, this slide shows that an actor's practice must always meet the threshold condition and then also meet either one of the two other conditions of the exception, either the patient protection condition or the care access condition. The threshold condition proposed requirements include an actor's good faith belief, a tailored practice, and the implementation of such a practice based on either an organizational policy or a case-by-case determination. Then, if that threshold condition is satisfied, an actor would additionally need to satisfy one of those other two conditions. First, the patient protection condition, which applies to practices that the actor believes could reduce the patient's risk of potential exposure to legal action based on the mere fact that reproductive health care was sought or received. Or, once satisfying the threshold condition, the actor would need to satisfy the care access condition, which we propose to apply to practices an actor undertakes with the belief that it could reduce potential exposure to legal action for healthcare providers or other persons who provide or facilitate receipt of care that's lawful under the circumstances in which it's provided. Next slide, please. The second new exception we proposed is the requester preferences exception. And here ONC proposed that when an actor honors a requester's preference that they have expressed or confirmed in writing for limitations on the amount of EHI made available to the requester, or the conditions under which EHI is made available to the requester, or the timing of when the EHI is made available for access, exchange, or use. So the benefits of this exception, it offers actors certainty that if they meet the conditions of the exception, they can honor these requester preferences without the practice constituting information blocking. It would benefit any requester, including individuals, healthcare providers, any other requester for permissible use of EHI that the actor has. And finally, to the extent the actor is able and willing to do so, it allows the actor to accommodate a wide variety of preferences in comparison to even similarly situated requesters. And this wraps up the information blocking section of the proposed rule. Next slide, please. Now I will talk about the TEFCA proposals in HTI-2 proposed rule. So just to start with some background, the 21st Century Cures Act calls for the development or support of trusted exchange framework, including a common agreement among health information networks nationally. And then on January 19th, 2022, ONC published in the Federal Register the Trusted Exchange Framework Principles for Trusted Exchange and the Common Agreement for Nationwide Health Information Interoperability version 1, which on May 1st, 2024, we updated in the Federal Register with the Common Agreement version 2.0, which implements like the latest industry standards and other changes. So now in HTI-2, ONC proposes to add an entirely new part 172, to Title 45 of the Code of Federal Regulations to implement certain provisions related to TEFCA that will establish the qualifications necessary for an entity to receive and maintain designation as a QHIN capable of trusted exchange pursuant to TEFCA. So going by subpart, ONC's proposals here cover the following topics. Subpart A is the statutory basis, purpose, and scope of the provisions, the applicability of the TEFCA provisions, and all the relevant definitions. Subpart B discusses requirements related to the qualifications needed to be designated as a QHIN. Subpart C covers QHIN onboarding and designation processes. Then in Subpart D, we propose RCE and QHIN suspension rights, notice requirements for suspension, and requirements related to the effect of suspension. And then next in Subpart E, we propose RCE and QHIN termination rights, notice requirements for termination, and requirements related to the effect of termination. Then the final two sections, Subpart F covers QHIN appeal rights and the process for filing an appeal to ONC. And Subpart G proposes requirements related to QHIN attestation for the adoption of TEFCA. And the policy rationale behind these proposals are here, but so they're consistent with the requirements established in the Common Agreement, the Standard Operating Procedures, and other TEFCA resources, and they're intended to complement and strengthen those requirements and procedures. ONC also believes that certain provisions, subparts A through F above, related to receiving and maintaining QHIN designation should be implemented through regulation to support QHIN appeals to ONC and to strengthen TEFCA's viability moving forward. Subpart G, which proposes the process for QHINs to attest to the adoption of TEFCA, is required by statute, the Public Health Service Act, to be established through notice and comment rulemaking, which is what we are proposing to do here. And that wraps up the TEFCA section.
All right, thank you very much, Cassie. I am going to talk a little bit about the resources we have available, the upcoming webinars, and just give a highlight on the public comment process. But before I do, I'm going to ad hoc a little response based on the feedback that we just received on the Protecting Care Access provision. Having done regulations at the state and federal level for nearly 20 years now, I've never had so many likes. So I want to say thank you for expressing your support and remind you that you can say nice things in a comment as well on the public comment process. So when you're commenting on the rule, when the comment period does open, it is actually extremely helpful to us if you not only tell us about things that you don't like or things that we should modify or things we should additionally consider, but also that you please do comment on the things that you support, things that you like, things that you think are important. Especially things that you think are a priority, that we should ensure that we're sort of making that policy and where we take that policy a top priority in any future final rulemaking. So I'm going a little out of order in where my comments are going to be, but I have never had that quite positive reaction. So I want to just thank you all and make sure that we're expressing that, you know, the public comment saying we got it right is really helpful because it also helps us as we're preparing the final rule. So we have several resources available, and I wanted to make sure I spent a little bit of time telling you what they are and where to find them, because I know that this is a very long rule, and I know that there were lots of questions in the chat that we haven't answered, including some that may not be interpretive, but it's very challenging for us to try and sort them out and parse them. So for the purposes of this webinar, we were not going to be doing direct answers to questions. However, there's some pieces for some of those questions that are not interpretive. The answers are in these fact sheets. So I wanted to make sure that you all knew where to find them. They are on healthit.gov/proposed rule. There are fact sheets as a general overview of the entirety of the rule, the US CDI version 4, including the individual data elements, the information on electronic prescribing, and the real-time benefit tool, which is an update to the base definition. I think someone asked about a base definition as well. The information blocking exceptions are on there, public health reporting, much more in-depth, some of the pieces that Molly was talking about that are really exciting, looking at that entirety to be able to do that circular transaction, a little bit agnostic to where the data is coming from or going to, and trying to think about it from the perspective of what are the functions that need to happen, and everything that Molly went through there. The Modular API, TEFCA, the patient, provider, and payer API that Alex went through, as well as a compliance date. So it shows what the different dates are for the certification program. I do want to remind everyone, those compliance dates are for the certification program. Nothing in this proposed rule would be applicable to other HHS agencies or their programs unless and until they did their own rulemaking to adopt those pieces, or after we finalize our rule, if they already have referential cross-references to our regulation, then those would promulgate through. So just to be very clear, you know, our rule, this rule is very much focused on the developers and the criteria updates. So those resources, again, are all on healthit.gov/proposed rule. You can also feel free to reach out to us and let us know if there's another type of resource that might be helpful. We're still working on a couple more fact sheets we're going to put up, just because this is a pretty big rule, a lot of substance in it. We also have the Federal Advisory Committee that we'll be going through. So there may be public-facing resources that come out of the FACA, and those will be readily available for the public to check out as well. Next slide. So the upcoming webinars, we have 3 more information sessions already scheduled. We will consider if there will be additional beyond that, but we know these 3 are definite. So next week is a PASS week, and the following week on July 30th, we will have public health, and that will be a deep dive on everything that Molly covered. Molly will be back in action, helping present and talk through those details, along with several other colleagues at ONC who have done some of the legwork on the technical pieces as well. We will have an information blocking session on August 8th, so everything that Cassie covered, more detail there, and filling in some of the gaps that folks may not be aware of from some of the prior rulemaking and how it all fits together. And then we'll be doing a patient, payer, and provider API, so all of the things that Alex covered in more detail and how they affect the sort of program guidelines and references that may be cross-referenced in our reg about other regulations as well. So those sessions will each be in more depth on each one of those topics, and that's the schedule for them. You can register for them on healthit.gov/proposed rule. Next slide. So this is the info that we sort of always do for how to comment on the rule. So as I mentioned at the beginning, the rule has been submitted to the Office of the Federal Register. The Federal Register has a process that they go through to format and publish rules. There are some requirements about how they do reg text and things like that. So we are working through that process with them, and when that is complete, it will be on display on the Federal Register as a PDF. They essentially put that display version up first so that it's available, and then it will publish after that. It will not be until it actually publishes that the public comment period will open. Now, there may be some differences between what we have made available on our website and what actually is published in the Federal Register because of that process that OFR goes through with especially, things like formatting and mandatory instructions and things that are sort of administrative pieces to it. We will not be doing a comparison on what the scope of those changes are. We just continually remind people that that's the version. When that version is published, that's the version to make sure that you are looking through for specificity for your comments and comment responses, because that's the official version. At that time, when that public comment opens, we will then know when it will also close. So we will be able to tell people that information as well. And then the regulatory reference number, the RIN, you can see that on this slide, but for those who want to just keep an eye on it, you can actually sign up for alerts on the Federal Register. I don't know if some of you don't know that, you should do it, it's fun. That the RIN is 0955-AA06. And if you go to regulations.gov, you can search for that and actually subscribe for any updates from ONC on the Federal Register. So with that, I will wrap us up and thank everyone for coming. We'll actually give you a few minutes back. Very, very much appreciate your attendance. Again, please keep an eye out. We will be sending out on our listserv. We will be updating our website as soon as the rule is published and the public comment period is open. And we are very much looking forward to receiving your comments and hearing about what you think of what we're putting forward here. We think these are some pretty exciting policies and proposals, and we're very much looking forward to public input on them. Last public service announcement, the Health IT feedback form. If you want to request a speaker, there is a form on that page as well. Again, we just be patient with us if during the rulemaking process there are some limitations to what speaking engagements we will do, but by all means, please reach out if you are interested in having any of our teams come and present to your organization. And I will stop talking now and thank you all very much for coming, and we will close out.